Okay, we are live, so we can get started. Welcome everyone to our this week's Tumor Talk. This is a joint effort between the Lenox Hill Department of Neurosurgery and the Journal of Neuro-Oncology. This week we're pretty lucky. We have some some cool presentations from the Queensland group, Dr. Sandler and Professor Sandy Hayes. We're going to be talking about physical activity and exercise in adults diagnosed with primary brain cancer. Systematic review they recently published in the Journal of Neuro-Oncology. So without further adu, I'd like to hand the floor over.
Thanks very much. So thanks, Dr. Patel, for the invitation to present today. So like you said, I'm Carolina Sandler. I'm an exercise physiologist, and my PhD was focused on exercise interventions for fatigue disorders and cancer survivors. And I have with me here today Professor Sandy Hayes, who has a background in exercise science and epidemiology. So Professor Hayes is the lead of our research group called the Improving Health Outcomes for People, or IHOP for short. And our aim of our research group is to improve the lives of those diagnosed with cancer through improving their physical activity during and beyond their treatment. And although here we're going to talk about physical activity in adults with brain cancer. Oh, let me go back. Sorry about that. This project just forms one of our broader projects. We've done lots more work in this space more broadly in exercise oncology and understanding the relationship between physical activity and cancer outcomes. So specifically, Professor Hayes has been involved in the development of the recently updated American College of Sports Medicine physical activity guidelines for people with cancer. And nationally here in Australia, Professor Hayes was involved in the development of the Clinical Oncology Society of Australia position statement on exercise in cancer, and I'm on the working group looking at the implementation of these guidelines. I'd also like to acknowledge the traditional custodians and the land in which we're meeting and pay my respect to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people. So since the early mid-2000s, there's been an exponential rise in studies evaluating the link between physical activity, including exercise, and a whole host of cancer-related outcomes, including survival outcomes. So this original research, which includes both observational as well as clinical trials, has been included and summarised in over 140 systematic reviews and meta-analyses. And this body of contributing research has involved a range of different cancers, looked at the relationship between physical activity and outcomes pre, during, and post-treatment, and has evaluated safety, feasibility, and the effect on a range of objectively measured and self-reported outcomes. So summarising that evidence, you can see here that there's a fairly extensive list of benefits for physical activity and exercise, including improvements in physical and psychosocial outcomes, managing side effects, as well as overall quality of life and potentially survival outcomes. So as a result of the strength of this evidence, recently in 2019, Australian and international organisations, including Exercise Sports Science Australia and the American College of Sports Medicine, have released guidelines promoting regular physical activity and exercise in cancer populations. And what these guidelines say is that all cancer patients or all cancer survivors should avoid inactivity and aim towards participating 150 minutes of moderate intensity exercise, as well as at least 2 resistance exercise sessions per week. But of course, there are limitations in that the studies that have contributed to this evidence primarily involve participants with more common cancer types like breast, colorectal, and prostate cancer that generally have higher survival rates. And so it's unclear whether high levels of physical activity it just told me it's recording, but I think that's okay. So it's unclear if these high levels of physical activity in brain cancer specifically are associated with improved health outcomes and survival, as well whether exercise is safe, feasible, and efficacious following brain cancer. And so that led us to conduct this systematic review. And this review had 3 distinct aims. So the first was to describe physical activity levels following brain cancer. And this is just trying to understand how much activity these patients were doing. The second was to understand the relationship between physical activity and health outcomes. And the third was to assess the effect of participating in an exercise intervention on those health outcomes. So we conducted this systematic review according to PRISMA guidelines. We also pre-registered the review on Prospero. And what we did was we searched a range of databases and also included relevant references from the included articles. And to be eligible for inclusion, we were looking specifically at adults with brain cancer, with either observational studies assessing levels of physical activity or exercise intervention studies. We also assessed the quality of the included studies using the Joanna Briggs Institute Quality Appraisal Tool, but we didn't exclude any studies according to quality because there were actually so few studies. We wanted to summarise what had been done to date. And probably just before we go further, I'd like to just distinguish between physical activity and exercise because they're two different things. So physical activity is any bodily movement, which does include movement during exercise, but it also includes other movements that people might do throughout the day, for example, commuting or running errands. On the other hand, exercise is planned and structured movement done with the purpose of improving fitness or health outcomes. An important distinction to keep in mind. So after searching all the databases, removing duplicates, etc., we ended up with just over 3,900 articles. After title and abstract screening and the full text review, we ended up with 16 articles from 15 different studies. And that included 2 randomized controlled trials, 7 prospective cohorts, 2 cross-sectional, 1 case report, and 3 case reports. So broadly speaking, the samples included anyone from the case reports to 243, an age range of 20 to 82 years, included a mix of high and low-grade glioma and mostly newly diagnosed as opposed to recurrent disease. So looking at some results now, so from our AIM-1, just the levels of physical activity in people with brain cancer, we had 6 studies contributing to this aim, and that included 2 cross-sectional and 4 longitudinal studies with a total sample size of 600. All of these studies use self-report measures of physical activity, so that's measuring physical activity levels via questionnaire. Now, the amount of physical activity during or post-treatment ranged from about 134 minutes to 177 minutes of physical activity per week. Regarding those meeting physical activity guidelines, so that's those 150 minutes of moderate intensity exercise per week, pre or at diagnosis, a range of 20 to 70% of patients were meeting those guidelines. And during or post-treatment, this range was 20 to 40. And this decrease in physical activity was confirmed in longitudinal findings, suggesting that the proportion of regularly active patients more than halved between pre and post-diagnosis. And then participants reporting no exercise at all ranged from 24 to 44%. So overall, there seems to be a decline in physical activity from diagnosis, and most participants did not meet physical activity guidelines at any time from diagnosis to follow-up, with about 60% characterised as insufficiently active or sedentary. So now looking at the association between physical activity and health outcomes, there was one cohort study of just over 200 patients with recurrent grade 3/4 glioma, and they found that baseline physical activity, so that's during or post-treatment, was shown to be an independent predictor of survival, with a median survival of 22 months for patients reporting over 9 Met hours per week. That's about 3 hours of moderate intensity walking, to 13 months for patients reporting less than 9 Met hours per week. So further, there were 2 prospective cohort studies that showed an association of physical activity and quality of life, so higher quality of life with increased physical activity and fewer brain cancer-specific concerns. Now, the evidence for the other outcomes were inconsistent between studies, but overall, physical activity post-diagnosis might be associated with better health outcomes, including higher quality of life and fewer brain cancer-specific concerns. potentially improve survival. Now, looking at the effect of exercise interventions on these outcomes, now if we actually intervene rather than just observing what happens with physical activity, there were 10 studies that looked at this question, including 3 randomized controlled trials, 1 case report, and 3 pre-post interventions in 3 case studies. So basically what you can see from this table here is that there was a combination of interventions both during and post-treatment. 4 studies investigated aerobic activity only, 4 looked at a combination of strength or resistance training and aerobic, and 2 looked at yoga specifically. And they looked at a range of outcomes. The interventions themselves range from 4 to 24 weeks in duration. The frequency that patients had these interventions was 1 to 6 days a week of 15 to 60 minutes. So regarding feasibility and safety, you can see there's quite a range in recruitment and retention rates. Now, the reason for withdrawal or loss of follow-up included illness progression, travel problems, returning to work, lack of motivation or time. There was 1 adverse event reported where a participant lost balance and fell, and they just reported soreness to their head. Average adherence to the number of sessions attended ranged from 60 to 100%. And then exercise was shown to be beneficial for symptom management and improving aerobic capacity, body composition, and physical activity levels. There was clinically significant, but not statistically significant improvements in neurocognitive domains, mental health, quality of life, mood disturbance, which were all supported by 2 small randomized controlled trials. So there are positive benefits, but also the strength of this evidence is quite weak in that it's mostly coming from small individual randomized controlled trials with sample sizes between 20 and 35. So overall, we saw what's similarly observed in other cancer cohorts, that the proportion of insufficiently active patients increases during treatment, and after treatment, levels of physical activity are lower for patients with brain cancer, so about 20 to 40% meeting guidelines, compared to more common cancer types like breast, colorectal, or prostate, where about 54% of them are able to meet guidelines. And that could be reflective of the unique challenges experienced by those with brain cancer, including disease and treatment-related side effects like instability, neurological deficits, fatigue, which might make engaging in physical activity particularly difficult. But on the plus side, exercise was safe and it was feasible, but a wide range in recruitment and retention rates suggests that integrating exercise is going to be complex. And patients were mostly newly diagnosed with comorbidities and side effects, with those with comorbidities and side effects often deemed ineligible to participate. So that observes that potentially there's a recruitment bias whereby the more well brain cancer patient is in participating in these interventions. And except for 1 study, all of the studies involved highly supervised exercise. So we don't really understand the safety of unsupervised exercise in this population. And this could be an issue because we know that access to exercise services could be inequitable with lower socioeconomic status, or those living in rural or regional areas unlikely to have access to supervised exercise. And so potentially telehealth, particularly in this COVID-19 context, might be a bit more appropriate. Of course, there are limitations to the review. So there were weaker study designs, mostly cross-sectional, that we had high attrition rates and with mixed cohorts, mostly newly diagnosed. There was also a lack of objectively assessed physical activity measurement. So these limitations likely influence our findings to be overestimates of physical activity as opposed to underestimates. And so that makes us question whether these physical activity targets that are set for all cancer survivors are appropriate and realistic and achievable for the brain cancer population. And so for future research, we need to have we need to understand research that might inform our what are realistic targets for this cohort, and whether these targets should differ according to brain cancer subtype or survivorship stage. And based on the current evidence, we need to cautiously interpret the potential benefits of physical activity and exercise. While acknowledging all those limitations, encouragingly, there are trends of improvement, in health outcomes, and exercise is safe and feasible. And when you look at it in the context of a robust and wider physical activity in our exercise oncology database, evidence base, this suggests that it's likely relevant and important to encourage those with brain cancer to be physically active, but we really need to individualise around the participant, keeping in mind those individual circumstances. Thanks very much.
Dr. Stanley, that was great. I mean, Professor Hayes, do you have any other comments or anything? I tried a few thoughts and some questions as well.
No, it's a good summary, I think, of the systematic review.
So I think, as a neurosurgeon, I think about how we sort of model our patients post-operatively. We see them post-operatively in the hospital, they're in the ICU, then they make their way to a floor bed or a telemetry bed, and they're working with physical therapy, and you're saying, okay, great, they're walking, they're eating, they're doing fine. But we don't see the stuff outside of the hospital where the majority of the recovery occurs. I think much of what we do almost is technical. We remove a brain tumor, we decompress, but it seems like a lot of the recovery, the more meaningful recovery, happens outside of our scope of practice. So the first question I have is, I know you guys have sent over some questions as well, is just something that I think about is that how do we motivate more of people like me on the surgical side to invest more in what you guys presented today? I think it's just so important, and it makes such a big difference on outcomes.
Absolutely. And I think actually there's been lots of studies showing that promotion of physical activity and exercise from the oncology team, the surgical team, the nursing team, rad-onc, etc., is key, because the patients trust you guys, and rightly so. And so understanding the importance of moving and trying to keep people active is quite important. I guess really what I would imagine would get people on the medical side excited about this is if we could show some really hard outcomes. So if we could understand that if we did this level of exercise or physical activity, we're going to have better patient outcomes. Otherwise, why would people invest in that? But there's a lot more work to be done, I think, in that space to try and be able to answer those questions. Sandy might have some more thoughts on this, though.
Yeah, you and I both headed in the same direction, Carolina. So I think we've had for over 20 years an evidence base that has demonstrated that exercise during and beyond cancer treatment will benefit a whole host of patient-driven or patient-important outcomes like fitness, strength, quality of life, treatment-related symptoms. It reduces the frequency and the severity of treatment-related symptoms. The list is long, and the evidence is consistent, and it's really quite compelling from the patient's perspective and the patient's life. Yet it hasn't been enough to systematically change practice. And we think one of those reasons is because of the hard outcomes that Carolina was alluding to, in particular survival. So there's probably three outcomes that we would consider absolutely fundamentally important that randomized controlled trials need to be assessing. One is survival outcomes. Two is cost effectiveness. So if it actually is effective, can we do it cost effectively? And three is treatment related, is adherence to treatment, because we already know that doctors have evidence to support that if they can get their patients to adhere to optimal levels of treatment, they're likely to have better survival outcomes. So the two things can work hand in hand. There's 4 big trials happening around the world that are specifically evaluating survival outcomes at the moment. In ovarian cancer is one that we're leading. There's one in prostate cancer, metastatic prostate cancer. There's one in colorectal cancer. And there's one that's been completed that's involved peripheral blood stem cell transplant. So I think in the next 5 years, we're going to see results from these trials and a demonstration as to whether exercise can in fact improve survival outcomes. If it does what we think it will do, then I think you'll see there'll be a change of practice practice that's ultimately mandated. So it's whether you want to be ahead of the game and make sure you integrate this now.
That's a really good point. I mean, I think across the entire medical spectrum, especially for our neurosurgical patients, anything from spine or cranial surgery, we're always pushing our patients to be up and out of bed as soon as possible. Obviously, bearing medical clearance, but you can see it. It's a fairly obvious thought that the more effort the patient can put in, or the more effort the caretakers can put in on physical activity, it should make a big difference. Now, on that same note, what about the concept of motivation? When you have let's say you have a glioblastoma patient who has Googled everything about it and saying, oh my God, I only have, everything online is saying I have 12 months, 15 months, 20 months of survival. What's the point? They may ask that question. How do we get past that? How do we motivate them?
Do you want to go first, Carolina? Sure. That's, I think, super important, and that's key. And I would say that that comes back to being patient-centered and individualized. So what's going to be important to that patient? So from a clinical perspective, if I get referred a patient like that, okay, what's important to you? Do you want to play with your grandkids? Do you want to be able to go to the bathroom by yourself? And what can we do to try and maintain your function as much as possible? We don't know how people are going to respond to treatment. We don't, obviously, there are the big stats, but we don't understand how individuals are going to respond. But we need to try and find that hook that goes, well, we know that from the studies show us that if we can maintain your physical activity, if we can maintain you moving, they might not like the gym per se, or they might not want to ride a bike, but there could be other physical activity that we can encourage them to do that might motivate them to keep active, and potentially even involving families or carers or friends, so that they're making the most of the time that they've got there as well.
Yeah, again, we're on the same line. It really is about acknowledging that the patient gets to choose whether they take up this form of treatment or not, just as they get to choose whether they have radiation or surgery or chemotherapy, and they make decisions all the time about, is it worth the risk, is it worth the effort, versus what kind of outcome will it bring. So I think we just need to make sure that patients are adequately informed as to, we're not just suggesting that they increase their physical activity through planned exercise because, we know exercise is good for us, it's good for everyone. If they understand the extent to which exercise can actually influence their health outcomes and potentially survival, then usually it's less about should I, and it will quickly become how do I, and that's where the workforce then has to get behind the medical profession to kind of step in and go, all right, well, we know how to get you there, and it's not a one size fits all. We're not going to send you off to the gym if that's not where you want to be. There's a whole host of things that we can do that ultimately should fit within their desires, their interests, to work towards their patient-driven goals.
So all great points. And, just along these same lines regarding motivation, if we can motivate our patients, here, in the States, we have a very privatized healthcare sector. Our healthcare economy is vastly different from the majority of the world, which creates economic disparities in what certain patients can access. And we see it at our institution at Rutgers. We have 3 major campuses, hospitals, and there's a major difference in the demographics, in the level of insurance, the level of financial, sort of responsibility, et cetera. And I see it, I've seen in my residency training that there's a massive difference in the not just level of motivation, but the resources that are available for patients. You guys, I expect don't have the same exact issues I bet in Queensland, but I'm not sure exactly what the model there is like versus ours.
We certainly have health disparities. I think you're right in that the extent of the health disparities are probably less wide, but it might be a bit dependent on what you're looking at in terms of maybe it's not so wide based on socioeconomic status, but it is certainly wide based on place of residence. Does a patient live in an urban environment versus more rural, regional areas? immigrants versus people born in Australia. The health disparities exist, and actually one of the things that the IHOP group is particularly interested in evaluating are exercise interventions that aren't going to extend or widen those health disparities, which is why we've paid real particular attention to telehealth delivered exercise interventions. And so Carolina made the point that the vast majority of the studies that have been done in the brain cancer setting are supervised interventions. And that's great for the select 10% of patients who might live within a 5 to 10 kilometre radius of the hospital that they get treated at. The vast majority of people aren't close to the hospital, and they can't access face-to-face supervised sessions on a regular enough basis to have both immediate short-term benefit and sustain it in the longer term. So we are pretty passionate about making sure that the interventions we evaluate are what we would consider real world, and that it is about giving people the support that they need during and beyond their treatment, but to really use strategies to ensure we're developing independent exercises as soon as possible.
It's a very valid points there, and we're sort of trying to keep this within around a 30-minute time frame. But I just want to emphasize, I think your study is different than what we typically see in our neurosurgical journals, and I think that's what makes it so unique and so special. Clearly, us as providers and neurosurgeons have a lot to learn beyond just what we see in our acute hospital setting, and I think all of us are slowly acknowledging that majority of the recovery that happens outside is just far more important than necessarily what we're doing in the hospital. And it just shows that there's so much need for more and more research on this, larger trials, et cetera. So definitely want to thank you both for joining us. I know it's very early there right now, and thanks for your contribution. What time is it? I'm curious right now.
6:30 in the morning now.
Wow.
It's not too bad. It's probably not so early for doctors, but
yeah, that's right.
Early, no, nonetheless. But we do appreciate your contribution to German Oncology, and we welcome you guys back to Tumor Talk and to submit more to our journal. Thank you so much.
Great. Thank you.
Thanks for having us.